A very warm good morning to all of my respected seniors and fellow residents. Myself, Dr. Samni Singh. Today, I welcome you all for today's clinical meet. Now, without wasting any further time, I would like to invite Dr. Puneet Saini to throw some light on the first topic, that is a rare case of gangrene.
Good morning, respected faculty and all my colleagues. Today, I'll be presenting for student clinical meet a case of Mr. IK. He's a 27-year-old male. He's a resident of Panchkula, Haryana and laborer by occupation. He presented to PGI with chief complaints of joint pains for 3 months, blackish discoloration of digits of lower limb for 3 months, and blackish discoloration of digits of upper limb for 1 week, and blackish discoloration of tip of penis for 1 week. In the history of present illness, the patient became symptomatic 3 months ago when he started having complaints of joint pains, which involved multiple joints. Small as well as large joints were involved, which was symmetrical in distribution. The patient also complained of swelling around joints intermittently with early morning stiffness that used to last less than 10 minutes. There was no association with physical activity. The patient gave positive history for Raynaud's phenomena. This was followed by development of gangrene of the great toe of right foot, which progressed to involve the other toes of the right foot and the dorsum of the foot over the course of the next 1 month. That eventually involved the toes of the left feet as well as the dorsum. For the past 1 week, the patient continued to involve the digits of both hands and the tip of penis. This was associated with pain in the involved fingers and toes, which was sudden in onset, mild to moderate in intensity, and continuous in nature. It was exacerbated by movement and cold. History of numbness and burning sensation in the involved digits were present. There was no relieving factor, and the pain was non-radiating in nature. The patient didn't give any history of claudication. The history of loss of hair was present. This was followed by, the patient also had a positive history for fever for 2 days, 3 months back, which was high grade in nature and documented at 103 to 104 Fahrenheit. It was associated with chills and rigors and intermittent in nature. The fever was relieved with antipyretics and it was not associated with any localizing sign. The patient also had complaints of generalized malaise for the 3 months, so much so that the patient eventually couldn't do his day-to-day tasks. In the negative history, there was no history of malar rash, photosensitivity, oral or genital ulcers. There was no history of any bleeding manifestation, petechia or purpura. There was no history of dyspnea, acute onset shortness of breath, hemoptysis or pedal edema. There was no lower urinary tract symptoms or hematuria. No history of dry eyes or dry skin. There was no history of DVT or pulmonary thromboembolism. In the past history, the patient was a recently diagnosed case of hepatitis C. The patient also gave history of pityriasis lichenoides et viroliformis 4 months back. There was no history of diabetes mellitus, hypertension or tuberculosis, no history of any past surgery in the past. In the family history was not significant. The patient consumed mixed diet and he was a chronic smoker. He used to consume alcohol in non-serogenic and was a known IV drug abuser for the past 1 year. He used to use heroin and the last use was around 6 months back. The patient also had complaints of loss of appetite with history of significant weight loss. The bowel and bladder habits were normal. In the journal physical examination, the patient was conscious and oriented to time, place and person. He was moderately built and nourished. Vitals, BP was normal. The pulse rate was 110 per minute and all peripheral pulses were palpable. Respiratory rate of 18 per minute. He was afebrile, maintaining a saturation of 94%. There was no pallor, icterus, clubbing, lymphadenopathy. There was no pedal edema and JBP was not raised. In the head-to-toe examination, the patient hair was thin and lusterless. Oral cavity didn't have any ulcers, although the mucosa shows some spots of black pigmentation. There was no crusting in nasal cavity. The nails were brittle and the shape of the nails were also altered. This is the picture showing the skin lesions. The patient had healed lesions with the peripheral hyperpigmentation and central hypopigmentation that was present over the trunk and arms. Few lesions also showed overlying scab. This is a picture showing the involvement of the digits of the upper limb. In the right hand, 2nd, 4th and 5th digits were involved, and in the left hand, The index finger was involved. The gangrene didn't extend beyond the metacarpophalangeal joint, and the associated shrinkage of the digits were also present. Some macrocyanosis was also seen over the over the thumb of the left hand. This is the image showing the gangrene over the toes of the bilateral feet. We can clearly see the line of demarcation between the normal skin and the gangrenous part. This image showing the gangrene over glans penis. In the systemic examination, respiratory system bilateral air entry was present and normal vesical breath sounds were present. CVS, it showed we could auscultate the pansystolic murmur in the left parasternal area. The per abdomen examination was soft, non-tender. Hepatomegaly was present with the liver span of 17 centimeter. Sounds were present and there was no free fluid. The musculoskeletal joint showed tender joint count of 7 out of 28 and there was no swelling associated with no other signs of inflammation. The CNS examination, higher motor functions were normal. The motor bulk were decreased, tone was normal. The power in all limb was 4-5 and the hand grip was reduced to 20%. There was no associated sensory deficit. So based on the history and examination, the provisional diagnosis of following provisional diagnosis was kept. That the first one is immune complex mediated vasculitis, cryoglobulinemic vasculitis. Second, infective endocarditis with embolic phenomena, as the patient was an IV drug abuser. Third, medium vessel vasculitis. And fourth, primary antiphospholipid antibody syndrome. Moving on to the investigations. In the CBC, the thrombocytopenia was noted. At presentation, his platelet counts were 66,000, which gradually improved over the course in the hospital. The markers of inflammation, that is CRP and ESR, were also found to be raised. In the coagulogram, there was an isolated APTT elevation. At presentation, it was 45.4. The autoimmune workup, the ANA was found to be positive, that is 2 positive, nuclear and speckled. dsDNA and anti-Smith antibody also came out to be weakly positive with low C3 and C4 count, C4 levels. In the APLA workup, it came out to be positive for all the 3 antibodies, that is lupus anticoagulant, anti-cardiolipin antibody, and anti-beta-2 glycoprotein. The viral markers, the patient came out to be positive. Patient was a known case of HCV, so anti-HCV antibody came out to be positive, and also total anti-HPC also came out to be positive. The septic worker was sterile with a procal count of 0.109 nanogram per ml. In the urine workup, the urine showed proteinuria 3+ with the urine protein creatinine ratio of 1.43. Some RBCs 5 to 6 per high power field and pus cells 7 to 8 per high power field were also found. In the radiological workup, the first investigation that was done was USG Doppler of bilateral upper limb, which showed universally reduced systolic velocity, although the flow was triphasic. The CTPA there was no evidence of pulmonary thromboembolism, although cardiomegaly with dilated pulmonary artery was present. The CT-NG of the bilateral lower limb didn't detect any abnormality. The CECT of the abdomen showed mild ascites and minimal left-sided pleural effusion. The 2D echo of the patient showed normal left ventricular systolic function with right atrium and right ventricular dilatation, severe tricuspid regurgitation, and severe pulmonary artery hypertension. The pulmonary artery was also found to be dilated. Now I'll request the pathology resident to please explain the next few slides.
Good morning, everyone. We received a sural nerve biopsy in which we found about 7 nerve vesicles. And on examination, we found that in the epineurium, there was a proliferation of the blood vessels, and there was a few blood vessels were showing fibrin thrombi, and few blood vessels also showed the hypertrophy of the media, and there was severe loss of the axons in the nerve vesicles. And these fibrin thrombi, they were highlighted on this empty stain Messen's trichrome strain, and the axonal loss was also properly highlighted on the Messen's trichrome. So these are the fibrin thrombi with the recanalization. And on performing the EVG stain, we found the intact internal elastic lamina and the endoneurium. This perineurium was unremarkable in this nerve fascicles.
Thank you, ma'am. So based on all these investigations, according to the ACR criteria, the patient had thrombocytopenia, non-scarring alopecia, pleural and pericardial effusion, proteinuria. In the immunological workup, antiphospholipid antibodies and SLE-specific antibodies came out to be positive with low C3, C4 count, making the total score of 27. So the unit's final diagnosis was a systemic lupus erythematosus with musculoskeletal, hematological, renal in the form of lupus nephritis, serositis and mucocutaneous involvement with secondary antiphospholipid antibody syndrome with pulmonary hypertension, query due to microthrombi, and systemic peripheral gangrene with penile gangrene. And management, based on the diagnosis for the peripheral symmetrical gangrene, the patient was started on low molecular weight heparin and discharged on oral anticoagulants, that is warfarin. And for the lupus activity, the patient was started on Visalon 1 mg per kg body weight and injection for cyclophosphamide 500 mg IV. The patient was also given for HPS, anti-HPC total was positive. The patient was also given anticaver. Moving on to the points of discussion, what is symmetrical peripheral gangrene, etiopathogenesis of SPG, and the treatment options available. Symmetrical peripheral gangrene is a rare clinical syndrome characterized by symmetrical distal ischemic damage leading to gangrene of two or more sides and absence of large vessel obstruction or vasculitis. It is often synonymously used with purpura fulminans, but purpura fulminans is characterized by acute onset, rapidly progressive purpuric lesions leading to skin necrosis, gangrenous changes of limbs or digits, and organ dysfunction. There is no sex or age predilection present. The incidence or prevalence of SPG is not known as it is a very rare entity, but the incidence of multiple limb gangrene in APS is 9% and in SLE it is 1.3%. The clinical feature, the first sign of SPG is the erythematous cold extremities followed by dusky discoloration of skin. Over the next 12 to 24 hours, cyanosis and hemorrhagic villi may develop in symmetrical acral distribution over the fingers and toes. And over the next 14 days, it progresses proximally with the line of demarcation. In the etiopathogenesis, the precise mechanism of vascular exclusion in SPG is uncertain, but conditions favoring microcirculatory dearrangements, vasospastic conditions, and the low output states, they lead to poor peripheral perfusion, and they provide the clinical setting for occurrence of SPG. Some studies suggest that it is a disturbed procoagulant-anticoagulant balance which leads to SPG. The ischemic changes usually begin distally and advance proximally to involve the whole extremity. In spite of the large number of etiologies for SPG, the DIC is the final common pathway in its pathogenesis. The triad of Schwartz reaction, low flow state, and hypercoagulable vasospastic condition lead to DIC, and the SPG acts as a cutaneous marker for it. In severe sepsis, the hypertension that leads due to cardiogenic or vascular cause, septic shock, they lead to acute ischemic hepatitis, and along with the disturbed procoagulant-anticoagulant and anticoagulant ratio due to the decrease in antithrombin and decrease in protein E, it favors the DIC and eventually leads to SPG. In the approach, if the patient with the ischemic limb gangrene presents, firstly we'll see the arterial pulses. If the arterial pulse is absent, then we'll think about the causes of the arterial occlusion, that is thrombosis and embolism. And if the arterial pulse is present, then we'll see whether the DIC is present or DIC is absent. In the etiologies, they're broadly classified into two segments, that is infective and the non-infective. The infective includes the bacterial causes, that is mainly Streptococcus pneumoniae and Staph aureus and Neisseria meningitis, although some cases have been reported with Plasmodium falciparum and viral gastroenteritis. In the non-infective causes, the cardiovascular, which leads to low cardiac output and low peripheral perfusion like MI, cardiac failure, and hypovolemic shocks are included. The use of vasopressor drugs like adrenaline, non-adrenaline dopamine are also the causative agents. Hypocoagulable states, including malignancies due to Hodgkin's lymphoma, ALL, and other neoplastic conditions. Some connective tissue disorders like SLE, and as in our case, antiphospholipid antibody syndrome, they all lead to SPG. This is a study that was published in Indian Journal of Dermatology. It shows that the 85 to 100% of the cases of the SPG are due to the DIC, in which the sepsis form the main cause, and the pneumococcus is the most common organism that is responsible for it. This is our own PGI data that was a MD thesis publication in which 112 patients of the peripheral gangrene were included, and the peripheral arterial disease was noticed in 71.4% of the cases. But the symmetrical peripheral gangrene was found to be in 6.25% of the cases, and all these cases had the cause as sepsis. The connective tissue disorders caused peripheral gangrene in 7.14% of the cases, and most of the cases were due to SLE, scleroderma, and mixed connective tissue disorders. In the investigations, we'll go in for the routine investigations, CBC, SCRFT, LFT, and chest X-ray. We'll rule out sepsis, so we'll send blood and urine culture sensitivity. To rule out DIC, we'll monitor serum lactate, FTP, and D-dimer. We'll also screen for connective tissue disorders, that is ANA and APLA. USG Doppler to see the arterial status, and the bone scan before amputation, so to see the extent of the involvement of the limb. The biopsy forms the most reliable form of diagnosis, and the most specimens just show microthrombi in the capillary lumen of the superficial and deep vascular plexus, accompanied by deposition of fibrin and subtle exavasation of RBCs, but neither vasculitis nor inflammatory infiltrates are observed in the vascular wall. The management has minimal evidence-based guidelines are available for the treatment, but we follow the multidisciplinary approach. The goal of the treatment is to halt the progression of the disease and remove the causative factors, prevent secondary infections, correct hypovolemia, and remove the non-viable tissues. The general management include padding, use of vascular boots and mittens, and minimize the use of vasopressors. In the medical management, if the DIC is present, then we'll treat the patient with IV fluids and IV antibiotics. If the patient has bleeding tendency, then we'll replace the coagulation factors. And if the patient has has chances of thrombosis, then we'll start the patient on anticoagulation and antiplatelets. Usually heparin is used in low dose, that is 300 to 500 international units per hour as continuous infusion to halt the progression of ischemic changes to frank gangrene. Low molecular weight heparin has also been used. The prostacyclin is another agent that's a promising agent because of its vasodilatory, antiplatelet, and cytoprotective fibrinolytic actions. Then other medical managements such as sodium nitroprusside, nitroglycerin ointment, and intravenous alpha blockers have been reported in literature. However, no proven clinical control trials are present. Piperacillin, rizapine, dextrine are also used in the treatment of SPG, but none have proven to be beneficial. In the surgical management, amputation of the involved digits, fasciotomy to reduce the extent of gangrene, and especially skin grafting is the management. This is a case report that was published in the Journal of Dhaka Medical College. The 45-year-old male who was a chronic smoker present with antiphospholipid antibody syndrome. He was started on low molecular weight heparin for 5 days, followed by oral anticoagulants, peripheral vasodilators, calcium channel blockers, and oral steroids. But there was no resolution of the pain and the symptoms. So eventually the patient underwent amputation. On the follow-up, he didn't have any more blackening or any new ulcer. However, the pain is still persisting. This is another case report that was published in BMJ Asia. The patient had symmetrical peripheral gangrene with antiphospholipid antibody syndrome. She was a female patient, but with medical treatment with the agents, her symptoms stabilized with the preservation of the peripheral skin perfusion pressure. The mortality rate, according to an article published in Indian Journal of Critical Care Medicine, about 18 40% mortality rate was reported, and survivors have high frequency of multiple limb amputations.